colleagues. Welcome to another IBD Gecko session. For those of you who are new to this platform, just to remind you that Gecko is hosted by the Gastro Foundation in association with Project ECHO at New Mexico. And generally we have these sessions on Wednesdays at 4:30. Today we have 68 registrations from 13 countries within the continent. Welcome to all of you that have been joining all along and all newcomers. Today we're going to concentrate on ulcerative colitis. And many of you on this platform will know Professor Watermeyer, who's based at the University of Cape Town in my unit. And she's going to talk about mistakes in ulcerative colitis. After she's done her talk, we will take questions, and then we will go on to the second presenter, who I will introduce thereafter. Please feel free to type in your questions in the chat as Professor Watermeyer goes along. Thank you very much, and over to you, Joe.
Okay. Thanks, Matt. Can you see my slides?
Yes, we can. Thank
and
you
can hear me, I assume, right?
Quickly.
Okay. So I'm just going to talk today a little bit about some of the common mistakes that I've encountered in my career in terms of the management of acute severe ulcerative colitis. Acute severe ulcerative colitis is a medical emergency. I always tell the fellows that I teach that it's really the GI equivalent of meningococcal meningitis, and it carries a very high risk of toxic megacolon and perforation. And if it's inadequately treated, there is a historical mortality rate of up to 75% at 1 year. This was, of course, prior to the development of effective medical therapy. So the first major inroads in the treatment of this condition came in 1955 with the publication of a seminal paper in the BMJ by Sidney Truelove. And in this paper, which was in fact one of the very first placebo-controlled trials ever conducted in the field of medicine, the mortality in the placebo arm was 24% as compared to a mortality of 7% in patients who were treated with high-dose oral corticosteroids. So obviously a dramatic difference. And over time, this mortality has been reduced even further with timely surgery, intravenous corticosteroids, and medical rescue therapies. In a specialist unit in 2021, mortality should be way below 1%. Unfortunately, if you look at centers where there are much lower volumes, and peripheral hospitals, for example, the results are not as impressive. And in fact, even recently, 5% mortality rates were reported in these low volume units. And obviously this is not acceptable because these are very treatable illnesses, and why are people still dying? So clearly there are common mistakes that are still being made. So one of these, first and foremost, and I think this is particularly applicable to sub-Saharan Africa beyond South Africa, is misdiagnosis. And there are many, many mimics of ulcerative colitis, ischemia, radiation, drugs, Crohn's colitis, but I think particularly infectious colitis. So the acute infections, particularly bacterial dysenteries due to Shigella, Salmonella, Campylobacter, and E. coli, these are unlikely to be confused with ulcerative colitis because they generally have a very short acute presentation, a short duration of symptoms. More often than not, stool culture will come back as positive, and of course, a rapid response to antibiotics. If, however, patients with an acute dysenteric illness do happen to undergo endoscopy, which seldom happens, their histology will show features of an active colitis, which in particular will show neutrophils within the lamina propria. But most importantly, in this situation, there will be no features of what we call chronicity. These are reports such as crypt distortion, basal lymphoplasmacytosis, and Paneth cell metaplasia in the left colon. If these features are found on colonic biopsies, it suggests that there has been a chronic inflammatory process which has been going on for some time, even if the patients have had a relatively acute presentation of symptoms. But there are certain chronic infections which are much more of an issue in the differential diagnosis of ulcerative colitis because they can closely mimic the condition and need to be excluded before IBD is confirmed, because obviously using steroids, immunomodulators, biologics could have tragic consequences if you are treating a misdiagnosed infectious colitis. So that is why in a first-time presentation, biopsies are absolutely mandatory to exclude all of these chronic infections. The first of these, intestinal tuberculosis. This is much more likely to be confused with Crohn's disease than ulcerative colitis, but there are, in a small number of patients, a presentation which looks very much like UC, a pancolitis. The second is a schistosoma mansoni infection, and this is picked up looking at the granulomas and the ovas in biopsies, and you can see that they have a lateral spine as opposed to hematobium, which has a terminal spine. Amoebic colitis, not uncommon at all, even in Cape Town, where it's not meant to be an endemic infection. We see quite a few in a year, and these are characterized by the flask-shaped ulcers as well as trophozoites that we're seen on intestinal biopsies. And finally, one that we don't see a lot here in South Africa, but we do see it in people who have come down from more north, would be strongyloides, which can give a colitis that looks exactly the same as ulcerative colitis, and you pick it up with larvae on intestinal biopsies. And the important thing about this one is if you treat strongyloidiasis of the colon with steroids, it is invariably a fatal condition. So you really have to be very careful you've excluded this. And some clues to the fact that you may have these parasites would be a high peripheral eosinophil count and lots of eosinophils on the biopsies. So the second problem is failing to assess the severity or to recognize that what you're dealing with is a severe attack of ulcerative colitis. So even in 2021, we still use the old true love and width criteria, which have really been around, seems like forever. And a severe attack is defined as having the passage of 6 or more bloody stools per day, together with one of any 4 additional criteria, which reflects anemia, pyrexia, raised inflammatory markers, or a tachycardia. And we tend to use a CRP in place of a raised ESR. Of course, the endoscopic appearance will also give you a clue as to how severe the attack is. And we tend to use the Mayo score. And if you look at the bottom there, that's Mayo 3. These are patients who have spontaneous bleeding and ulceration. And these patients, needless to say, are in the throes of a much more severe attack than if they have pictures that you see up at the top, Mayo 0 or 1. The more true love and Witts criteria a patient has, the higher is the risk of colectomy. For example, if they have 6 bloody stools a day together with one of the additional criteria, the risk of colectomy is 9%. If they have 2, it's 31%. And if they have 3 or 4, this skyrockets up to almost 50% colectomy rate. Other predictors of colectomy are the presence of mucosal islands, thumb printing, or dilatation of the colon on abdominal X-ray, as well as hyperalbuminemia. These are both very good predictors of colectomy. And the importance of this is to try and identify high-risk patients so that they can be treated appropriately and aggressively. Because really, this is, as I said, a potentially lethal condition. And the third main problem that we see is unnecessary delays in referral. And I've already alluded to the difference in mortality rates between a unit which sees a lot of these cases of ulcerative colitis and those where there is a very low volume. So why is an unnecessary delay in referral to more specialist centers? Well, of course, patients may not want to leave the local hospital that they're at. Doctors often hang on, hoping that the patients may still turn the corner. Bed availability, something that we have a major problem with in Cape Town. Perhaps ignorance, not being aware of the condition as much as is possible. I cannot emphasize enough how the management of acute severe ulcerative colitis requires early and aggressive medical and surgical therapy if necessary, ideally in a specialist unit under a multidisciplinary team with a gastroenterologist, colorectal surgeon, and stomatherapist. So we need really to educate our colleagues as much as possible to recognize acute severe ulcerative colitis. And for those of you who do not have access to a multidisciplinary specialist team, at least to be able to recognize it and know how to treat it safely. Even when a patient is in a specialist referral center, there are still unnecessary delays in the referral process. And very often, again, colectomies are deferred. And surgeons are often only informed many days after the patient has been admitted. So to avoid this, really, surgeons need to be involved right up front so they know there's a patient with acute severe ulcerative colitis sitting in the ward. Ideally, the stomatherapist should also be involved right up front. Patients need to be educated about having a stoma. This is an IBD patient's greatest fear, and especially if this is the first time presentation of their acute severe ulcerative colitis. Imagine arriving in hospital with some bloody diarrhea, and 1 week later, you're stuck with a stoma, and nobody's given you a little bit of time at least to try and understand what your life is going to be like. The fourth important mistake is excluding concurrent infections. And I'm particularly referring here to Clostridium, should we say, difficile and CMV. The risk is particularly high in patients who are on immunosuppressive agents, but it's also higher in IBD per se than it is in the general population. And the importance of C. diff and CMV is both of these infections, if they are concurrently present with acute severe ulcerative colitis, it increases the colectomy rate and increases the mortality rate. So needless to say, we have a knee-jerk reaction where C. diff is checked with every single flare that a patient has. CMV is another very important thing to consider because CMV absolutely loves the sick colitic colon. And if patients have concurrent CMV colitis together with acute severe ulcerative colitis, it often renders the patient steroid refractory. So you cannot get on control of the disease without actually treating CMV. So to do this, we check every patient on admission with a flexible sigmoidoscopy and biopsies, looking for inclusion bodies or immunohistochemical staining. And if we do pick up CMV, we will treat both the acute severe ulcerative colitis with steroids as well as the CMV with intravenous ganciclovir. The fifth common mistake made in the treatment of this condition is omitting venous thromboembolic prophylaxis. Patients with IBD suffer from significant thrombophilia. They have very high risks of DVTs and pulmonary emboli, particularly when they have active inflammation. So as a result, all patients who are admitted with this condition should receive low molecular weight heparin. They should be encouraged to mobilize, compression stockings if this is possible. And just to point out that rectal bleeding, unless it is very, very severe, is not a contraindication to the use of low molecular weight heparin. The sixth mistake that is often made is the choice of analgesia. And a very important thing to understand about ulcerative colitis is that it is not a disorder characterized by significant pain. This is unlike Crohn's disease, where pain is the cardinal symptom. If a patient with UC has significant pain, it suggests that there's transmural inflammation and that the patient's in a lot of trouble and that there's already a high risk of perforation, or they may already have perforated. And if a patient has severe pain in UC, it's an indication to get an urgent chest X-ray and abdominal X-ray. You hopefully don't want to see free air under the diaphragm as you're seeing in that chest X-ray, and a very low threshold to do a CT scan. Most importantly, the pain of ulcerative colitis is not an indication for opiates. In fact, opiates in this condition can precipitate toxic megacolon. They are known to increase the risk of infections and to increase the mortality rate. Despite this, 70% of acute severe UC patients in the United States of America receive opiates during that admission. One also has to be cognizant of other drugs that interfere with colonic motility and must be avoided because, again, they can precipitate toxic megacolon, in particular Imodium, loperamide, but any other agents which have anticholinergic properties should really not be used while the patient has an acute severe attack. What should not be done? Broad-spectrum antibiotics are not indicated unless you suspect that the patient is septic. TPN of no value at all, and neither is bowel rest. Another important mistake in treating acute severe ulcerative colitis is delaying rescue therapy. So I've already alluded to the fact that intravenous steroids are the cornerstone of management of this condition. We typically use 100 milligrams of hydrocortisone every 6 hours. It really works amazingly well. In about 70% of patients, you come to see them the next day and their symptoms are resolving, their stools are starting to form, the blood is gone, temperature's down, tachycardia, and they're still fantastic. But unfortunately, this is not the case in about 30% of patients who fail steroids. So if by the third day of intravenous steroids, the patient has not improved substantially, as I said, this is a rapid response, then the ship has sailed, the patients are proving themselves to be steroid refractory, and one needs to consider rescue therapy, which is either infliximab or cyclosporin, or alternatively, if there is another indication, to go directly to a colectomy. We try to use medical therapy because we know, save the colon in the setting in many instances, but it is a very short window of opportunity. So this is the time not to procrastinate. So why is there this hesitation to do rescue therapy? Well, a number of reasons. Again, everybody likes to hang in a little bit longer, hoping that steroids will kick in today. Clinicians may be unfamiliar with rescue therapies, and of course they may not be available because of costs. Infliximab remains a relatively expensive drug, as does cyclosporin. So how do we predict steroid failure? Well, we use what is called the Oxford Index. It's very simple. It's been around since about 1998 already, it's easy in clinical practice. So what this index suggests is if on day 3 of intravenous steroids, this patient's CRP remains above 45 and they're passing between 3 and 7 stools per day, or they are passing more than 8 stools a day, regardless of what the CRP level is, then these patients are steroid refractory. They have an 80% chance of coming to colectomy on that particular admission. And this is very important because these are the patients that need rescue therapy as soon as they declare themselves to be steroid refractory. And the choice of infliximab or cyclosporin is really dependent on availability, on what the attending clinician feels comfortable. We now have a few randomized trials which show that these rescue modalities are of equal efficacy. Very importantly, there's always the risk of missing toxic megacolon or perforation. And this is really important in patients who have now been administered high-dose intravenous corticosteroids, because as soon as they have steroids on board, the abdominal palpation becomes entirely unreliable. Steroids mask the signs of peritonism. They also suppress pyrexial response. But in our clinical experience at Fortescue, persistent tachycardia and pain are probably the best clues that the situation is not really much better. And we all recommend in our unit serial abdominal x-rays and chest x-rays, ideally daily, although the pathologists start to get a little bit irritated with that, but at least every second or third day. And we have a very low threshold for doing a CT scan if there's worsening of pain or distension, even if the x-rays are fine in case there is some sort of microscopic perforations. Another mistake is delaying colectomy. As I've alluded to, there are major advantages in the medical therapy of acute severe ulcerative colitis, which allow us to give patients a shot at saving the colon, a shot of not having a stoma, and avoiding an ileoanal pouch down the line. And as a result of this, patients are being referred for surgery later and later. And this delay is not without consequences, because by the time they're having colectomies, they're often in a poor state of health, malnourished and anemic. And we also know that they are then quite steroid saturated. And it's been shown that if you persist with medical therapies beyond 8 days, there is a significant increase in major complications. In particular, it is the prolonged use of corticosteroids and poor nutrition that increases this risk. And the risk is notably for anastomotic leaks and for sepsis. And our surgical colleagues really hate operating on these steroid-saturated patients because they can just sometimes fall to pieces. It's been shown that there's a 2-fold increase in in-hospital mortality if colectomy is performed after 6 days. So there really is no benefit extending medical therapy beyond 7, at maximum 10 days. So take-home messages: acute severe ulcerative colitis is a medical emergency. Mortality remains appreciable outside specialist units. There are several common mistakes that can be avoided. One must try to identify high-risk patients and refer promptly for management in a specialist unit if that is possible. If it's not, phone a friend. Early and aggressive medical therapy is key, and ideally there should be a multidisciplinary approach up front. Always make sure that you've excluded those chronic infections I've alluded to first, before you make the diagnosis. Exclude CMV and C. diff with every single flare. Make sure that, if possible, that you have a physician, a surgeon, and a stoma therapist involved from the time the patient's admitted, so there's no nasty surprises a few days down the line. Predict steroid failure early and institute rescue therapy. Beware of subclinical perforation and toxic megacolon when patients are on steroids. Do not persist with medical therapy past 10 days. Timely surgery is key. Don't forget venothromboembolic prophylaxis. Avoid opiates and anticholinergic medications. There is no need for routine broad-spectrum antibiotics, TPN, or bowel rest. And ultimately, the management of acute severe ulcerative colitis is about saving lives and not colons. I thank you, and I will stop sharing.
Great, thank you so much for an excellent talk. A really important topic, because as you say, this is certainly one of our medical emergencies in gastroenterology, one which a fellow must come out for. You know, when consulted about these patients in the middle of the night, I think it's not the sort of condition where you can have the intern or the medical officer look after the patient, because minor subtleties can be missed. And we've seen that happen here. So certainly it's one of the conditions to be taken really very seriously. And as you say, Joe, the involvement of the multidisciplinary team early on is key. So we tend to inform the surgeons on the first day that the patient is admitted so that as Professor Watermeyer says, if on day 3 things are not looking good, the patient is aware and the surgeons are certainly aware, instead of now having a critical emergency in preparing the patient for colectomy at that late stage. There are no questions yet on the chat. I encourage you guys to please post any questions, either with patients that you've dealt with that have been difficult to manage, or how you indeed manage a patient who's refractory to steroids. But I do have a question, Jill, from your talk. So we have a problem with this all the time. I noted that you listed CMV as a co-infection rather than as a standalone mimicker of UC. So are there situations where, in the absence of immunosuppression, a person can have CMV colitis, which actually looks and presents clinically and endoscopically like UC? Or is it almost always, in this context at least, an association or a co-infection in the presence of severe colitis?
Yeah, sure. Okay, so Masha, I mean, generally in acute CMV colitis, as you may see in a more advanced HIV infection, it's usually going to be an acute sort of infectious enterocolitis. So I'm not really alluding to that. I'm more alluding to the interface between CMV and acute severe ulcerative colitis, where the two conditions coexist. And we know that if you don't treat the CMV, you will not get on top of the acute severe ulcerative colitis. Hence, we treat with both corticosteroids and ganciclovir.
And I remember when I was training, there was this whole brouhaha about whether the colitis, the CMV that's seen, is a bystander or actually invasive disease, etc. But I mean, I think you've said it again, that it really is a moot point in the context of acute severe UC, and you find CMV on histology, you have to treat. Is that correct?
Yeah, absolutely. I mean, that debate, I don't know if it's ever going to go away, but we all know anecdotally that you treat them with ganciclovir and the steroids suddenly start working. Okay. So I see there's a question on the chat actually about immunosuppressants and disseminated CMV. So these are not really systemic CMV infections. These are CMV colitis in the setting of acute severe ulcerative colitis. So no, we don't worry about that. We actually just treat with ganciclovir and the intravenous corticosteroids, and we've never run into a problem with CMV septicemia as such, or disseminated CMV.
Yeah, and I must say, Mpo, anecdotally, the patients that we've had who were refractory, not responding to medical therapy, it turned out that some of them, after the fact, you know, when we've had the resected specimens, they actually had CMV. So it certainly is something to consider upfront and look for continuously in patients who you are struggling with. Are there any other questions, colleagues? Feel free to unmute and ask the question.
So Mash, I think there's just one other point that I want to make, and I think it's something that's not widely appreciated. If you admit a patient with acute severe ulcerative colitis, I'm talking the proper one that I've mentioned here now, not just somebody who's niggling along. Try not to start 5-aminosalicylates on that admission, because there are some people who actually develop paradoxical diarrhea on 5-ASAs, and it really confuses things. 5-ASAs have no role to play in the treatment of the acute severe attack. So just leave them alone. Stay away from the 5-ASAs, restart them when the patients are discharged.
Thanks, Jill. And maybe when you are there, you might as well clarify another issue that used to be an issue, but you know, we've dealt with it. Some people believe that if you give IV iron during the acute phase, it might cause increased inflammation and worsen diarrhea, etc., etc. Was there ever evidence to this? And maybe for the purposes of the fellows that are not training here, will you just let them know what we do and what doesn't really concern us?
Yeah, okay, so I think we'll all agree that oral iron is not a great idea when you've got active gut inflammation. It's very tricky mechanism through free radicals, etc. But so oral iron should always be avoided if there's active inflammation. We are very liberal in the use of intravenous iron in our patients. We want to, wherever possible, avoid having to transfuse patients down the line when the ulcerative colitis is under control. So we have thresholds, you know, anybody who's got an HB below 10 should get intravenous iron. And if they have active inflammation and they're iron deficient, again, intravenous iron is certainly the way to go.
And after the IV infusion, do you advise oral iron even once a day, or you rather repeat the indices 6 to 8 weeks later and see if the patient needs a top-up?
Yeah, I think so. I think until the active IBD is under control, oral iron is poorly absorbed. and most of it just rattles down and is passed out in the feces anyway. So if it's going to cause mischief and not be particularly effective, then we may be causing more damage than harm by throwing iron around, oral iron around, when we can use intravenous iron. And I think, although it is more expensive, obviously, preparations like Cosmofer are not exorbitant. Or in our setting, I'm not sure about our colleagues in the rest of sub-Saharan Africa, but in our setting, Cosmofer is affordable.
Yeah, indeed. And just to add to what, is there somebody who wants to say something?
Yeah, Mesh, I've got a question for Jill.
Hi,
Yes,
Rob.
please go ahead.
How are you?
I'm good. You?
Good, good. I just wanted to check how, let's say you have a patient already on Revelex who comes in acute severe ulcerative colitis, and how that would change your management. Would you then top it up? Would you then give cyclosporin, or would you more rapidly progress to surgery?
Look, Rob, I think it depends on how comfortable you feel using cyclosporin. I don't feel particularly comfortable. You've worked in our unit, you know the reasons why, because of the complexities of actually using it, and then also how do you hold the patients once you discharge them. So in that setting, I must say, I would make the assumption that the Revelex has probably been leaking out, and I would top them up as much as I possibly was able to, given financial implications. And of course, if that doesn't work, then one would certainly consider using cyclosporin in that setting. And I think in the future, we're going to see a big role for tofacitinib in the setting. It's an excellent drug. For those of you that don't know, it's a JAK inhibitor. It works very rapidly. It actually works as rapidly as steroids. And it doesn't have the pharmacokinetic problems of the biologics. Because it is a small oral drug, it is not lost to the colonic mucosa like biologics, which are proteins. So it has very predictable metabolism. So that may well be a role in the future. It's approved in South Africa, but it would be off-label for acute severe ulcerative colitis. That's not the indication at this point. But there's work going on into that, and I think that would be a very interesting option down the line.
Yeah,
definitely. Thank you.
Thanks, Rob. Nice to see you online. Are there any other questions before we move on to the case presentation? If there aren't at this point, there's no problem. If you think up of anything else that was discussed by Prof Watermeyer, so please put the questions on. We can still address them later on. Our second speaker, I'm pleased to say, is a fellow who's training at Steve Biko with Professor Khomo. His name is Modise Mokoni, and he's kindly agreed to talk to us about a case that they had with the refractory UC. Mokoni, over to you. Excellent, we can see it. Just please put it in presentation mode. Thanks.
Hello?
It's on. That's perfect. You can go.
You can, okay. Good evening, everybody. Is it visible now?
Yes, it is. And we can hear you perfectly.
Okay.
Yeah.
Okay. Thanks, everybody. As a way of introduction, I'm Dr. Mkoni, as Prof Steady has mentioned. I'm a fellow in the gastroenterology. I just recently joined after 6 months with the department. I'm going to be presenting an important, very interesting case that I think after this discussion, I've actually learned a lot. Hopefully the treatment of this particular patient will be much better after this. It's a 63-year-old lady that I saw, a pensioner, widow mother of two, originally from the rural area of Hampashe in the Limpopo province, who recently relocated to Pretoria West to stay with her son, who works in a hospital. The reason for relocation was due to a current medical problem that I'm going to be discussing. Mrs. MR had been well on, she previously worked as a domestic worker, and she never suffered any chronic illness and never been on treatment. She admits that she had never had any other medical problem except for visiting traditional medication doctors for minor ailments like flu. Her medical problem began around in the winter of 2020, while one of the days in the morning she began experiencing an intense abdominal pain, which was tending from the upper abdomen to the lower abdomen. This pain was subsequently followed by a bloody diarrhea for the rest of the day, that she even lost the count of the number of stools. She even had to be woken up several times at night due to the ongoing diarrhea. At that stage, she did not report any history of nausea and vomiting. She also had been feeling a feeling of incomplete bowel emptying. She then consulted the local GP at the nearby town, where she was advised to be hospitalized due to diarrhea and dehydration. She was then hospitalized at the local hospital for a few days and then subsequently was discharged at the request of her son. She did feel better, and the diarrhea had continued, though unabated. She was subsequently seen at our unit, gastroenterology unit, in around July 2024 endoscopic examination, where a diagnosis of non-specific pancolitis was made. These were her initial treatment, Asacol, azathioprine, and prednisone, and steroids were tapered over time. Though her bloody diarrhea settled, but occasionally had some breakthrough blood in her stools, and her bowel movement had improved over time from more than 10 movement a day to about 6 times, with a fewer nocturnal symptoms. I then saw her almost a year later, last month, at the clinic with the worsening symptoms of recurrent bloody diarrhea, with the left iliac fossa pain, which was on and off, which was temporarily relieved by defecation. She also noted that certain foods like pea and dairy products tended to aggravate her symptoms. She reported occasional nausea, but there was no vomiting. I must mention that she had no joint pains or any other extraintestinal symptoms at that stage. She was very compliant on her prescribed medication. She is a woman of a sober habit. She's born in a family of 4 with no family history of chronic diarrhea. Both her parents passed on in the 80s, nothing of note on her systemic inquiry, and she reported no fever. And at that stage, we decided to admit her and co-manage with colorectal surgeon in our unit. On her clinical examination, she looked mildly dehydrated with pallor of mucous membrane, mild pallor. She was of normal weight with a BMI of 19. Her blood pressure was normal, but she had tachycardia of 100 beats per minute. She was afebrile with temperature of 36. She was not jaundice, no adenopathy, and she had no digital clubbing with no pedal edema. Her abdominal examination revealed left iliac fossa tenderness on deep palpation with no masses palpable, and she had increased bowel sounds. The PR examination was normal with normal anal sphincter with no hemorrhoids, but the glove noted, we noted had fresh blood mixed with some mucoid stool. There was no canomegaly, no ascites. Other systemic examination was essentially normal. This is some of the investigations that we did in the hospital. The abdominal X-ray, you can note, if you note there, there's not much. We're looking for perforation, toxic megacolon, which we didn't think he had. Unfortunately, if you look at the I don't know if everybody can see that. This was the day of admission. Calprotectin was 2018, and CRP at that stage of admission was 105 with the normal, essentially normal PCT. She had hypokalemia, which we corrected, and fluids and potassium replacement. The hemoglobin was 11.2. I think we probably think it was because of was dehydration. The subsequent 2 days later dropped to 10.7. The liver function test was essentially normal, but we noted the albumin was 27, which was low. The white cell count was essentially normal, and the rest of the test, thyroid function, we did quite several tests. The ESR on admission was 76. The stool test, which we did, with no parasites, no bacteria, Clostridium difficile toxin was negative. Salmonella, essentially there's not much we could pick up on the blood, on the stools. As I mentioned, I've mentioned about CRP, PCT, and CRP, and all this essentially were negative. We also did the CMV test, which was negative also. This was the histology of the patient at the time when it was done. It's when you look at the histology, it clearly says there were no granulomas, just severe colitis in keeping with dense inflammatory infiltrate. Plasma cells, eosinophils, were no crypts observed. This was more like a non-specific colitis. This was supportive treatment. The patient would continue the treatment in the hospital. We replaced the potassium steroid. We started 100 milligrams 6 hourly. I think this is where Prof Jill talked about maybe we should have omitted the ASUC for now and continue the steroid. And then Clexane subcutaneously was given for thromboprophylaxis. This was the progress in hospital. The diarrhea improved from more than 10 stools per day to less than 5 a day. And the blood in the stools also improved significantly, but occasionally you would have some spotting there. Abdominal pain improved quite significantly, though it's lagging slightly behind. Tachycardia on the second day had actually improved from 100 to 70, with things probably related to fluid replacement. These are some of the things just a summary of what I said previously, and that on admission, the CRP is almost to near normal. I think it was 5. ESR from 76 to 34. The HB, which dropped quite significantly to 9.9, and was hypoalbuminemic. So my impression of this patient was a lady who had acute severe ulcerative colitis. The patient was refractory to steroid and possibility of colon salvage therapy. She was due to follow up in 2 to 3 weeks. Unfortunately, this patient was readmitted yesterday, again with severe diarrhea of more than 10 stools, though this time around he didn't have any blood in the stools. Sorry, apologies. Now these are the questions that I looked at, looking at the histology of the patient. Are we dealing with ulcerative colitis? Should we have a repeat colonoscopy and biopsy? Should I consider other alternative colitis like ischemic colitis? And then lastly, as I said, we should consider colon salvage therapies like biologic or colectomy. I thank you, Prof. Thank you so much.
Thank you so much for that presentation. I have to agree that this is not the easiest diagnostic patient that you've had. For one, she's elderly, presenting for the first time at this age, having been well previously with the chronic diarrhea, which apparently seems to be refractory, at least to the therapy administered so far. And like we sometimes experience here, the biopsies are not really telling you whether this is just focal colitis or whether this is in fact chronic colitis, because she did not have features of chronicity, at least as reported on that biopsy. And then there are other issues like whether one would start azathioprine in an elderly patient for the first time at this stage. So I mean, I think you are right to present this case. There are many challenges. One of my questions would be, at the index colonoscopy, was the rectum involved? And how would you describe the endoscopic picture? And how far did you guys go up? Did you do a full colonoscopy, or was it a flexi? Or
the report that was on the file, this patient was done a year ago. The report was this patient had pancolitis all the way. Yeah, the whole from the rectum up to the cecum involved. It was entirely involved, and there was a lot of
on the severity of the pancolitis.
They put it like it's more like Mayo 2. Yeah.
Okay, right. So so presumably the rectum was involved, and because it sounds
the rectum was involved throughout until to the cecum.
It sounds like it could have been UC, except that the histology doesn't really quite fit. Joel, how would you tackle this one? I mean, it's quite tricky, I'd say.
Yeah, I think, I mean, the history of it's a fairly chronic, longish story, is it not? When did it first start for the very first time?
I think last year, around last year. Yeah, almost. It's almost a year now.
So it's over a year. So that kind of is the one thing that's pushing you towards ulcerative colitis. Okay. Elderly patients, of course, they do develop ulcerative colitis. It's not as common as in a young person. The typical age of presentation, as you know, is sort of late adolescence, early adulthood. So that is a bit odd. So I still think you're very likely dealing with ulcerative colitis here. But clearly, she's having severe disease. It's not being held by the azathioprine. It's not being held by the fiber-salicylates. So you need to step up therapy to a biologic. And before you do that, you've got to be absolutely certain that those things I mentioned in my presentation, particularly CMV, that you're absolutely certain that you've got that out of the picture. And you need to ask your pathologist to actually do immunohistochemistry, just to make certain that you're not dealing with it. If you've got access to PCR, that would be good too. And have a very low threshold to treat for CMV if you think that there's any suggestion of CMV. And then, of course, as I said, rule out C. diff. And then, yeah, go in there with a biological cyclosporin, whichever one you feel comfortable with. Just to clarify, sorry, the point that you made there, I think I might have misworded things. The fiber-salicylates, it's absolutely fine if the patients have been on them, because they're not going to cause any mischief. So if you want to keep them on when they're having a severe attack, we don't tend to, because it's just swallowing pills unnecessarily at that point in time. But it's particularly initiating 5-ASAs during the acute attack that might actually muddy the water, should we say.
Yeah. I mean, one of your questions was whether we should scope her again. I certainly would do a flexi on this admission and take biopsies and as Jill says, have them exclude CMV, and maybe just to report again and look more carefully at the histology. And of course, repeat the stool, sample and all of those things that you would do anyway. I certainly would do that. Jill, are you concerned at all about, so VG says having a relook endoscopy. Yeah, VG, I would agree, but maybe a flexi, not necessarily a full colonoscopy at this stage. So I presume because of her age, etc., at some point it started to sound like she might be having a diverticular disease with a diverticular bleed, etc. So I presume that she definitely does not have any diverticuli, either radiologically or at endoscopy, Modise? No.
No. Endoscopically, nothing was reported of diverticular. No.
Okay. And do you guys have access to TPMT testing, or you have to send the sample somewhere else?
I don't know. I don't think it, just the blood test. No.
Okay.
I'll just have to. I'm not sure. I'll have to ask. Prof. Okay. I wasn't sure. That's the enzyme you check for.
Yeah.
Yeah. For azathioprine.
Yeah. Jill, are you concerned? I mean, we if somebody has been on azathioprine forever and now they're in their 60s or whatever, we generally try to see if we can change it to something else, you know, because of the risk of malignancy, etc., with aging, etc. Would you start it at age 60 something for the first time?
Never.
Yeah.
So yeah, I azathioprine, it's got lots of problems in older people, and the definition of what an older person is, for me, it's going further and further down the line. But generally, anybody over the age of sort of 60, 65, try and stay away from azathioprine. It certainly increases the risks of a number of different cancers in that age group. So while it's not unacceptable to use it, if you do have other options, they would be better. And obviously the anti-TNFs are generally pretty safe in older patients, not as safe as they are in younger people, but they would be a much better option, obviously. But, you know, often in state practice, we know everybody's hands are tied, and it's not always what we want that our patients will get.
Yeah. Yeah, I must say, I'd agree with you, say that maybe I would be a little concerned about the ASA at this age. But as you know, as Joe says, it's not a train smash if there weren't any other options. And by all accounts, she sounds generally healthy, you know. And you know, if that's all you have, then that's all you have. VG is asking about whether there was any comment on the ileum when the colonoscopy was done, and is there any role for CT enterography at this stage? VG, I'm not sure that there'd be a role for CT enterography, because I think what we need is tissue diagnosis for what's going on. So, and even with the ileum being normal, the phenotype from the presentation and the report, it sounds like it's UC. You know, I don't personally have any concern for the possibility of Crohn's disease in this patient. And in any event, even if he had Crohn's colitis, the management would be similar.
Amish, can you hear me?
Yes, Rob, go ahead.
So I wanted to make a comment. I thought that her initial presentation was very atypical for ulcerative colitis, in that one day she seemed fine and the following day she had acute severe bloody diarrhea. And in my experience, that sort of history is quite classic for an ischemic colitis. Ischemic colitis would probably fit with an elderly person as well. So I think what would be of value would be an experienced endoscopist having a look and just seeing, you know, maybe there is some rectal sparing, maybe, you know, maybe it's a typical ulceration pattern of ischemic colitis, and they're calling it a pancolitis, whereas, you know, it's an ulceration involving the whole colon, but it's not confluent throughout the colon. And then maybe a CT angiogram might be a good idea as well of the abdomen, just to assess for vascular pause.
I agree with you, because as I say, when I heard the story, it sounded like diverticular, ischemic, whatever, but this is somebody who had no premorbid conditions and therefore no risk factors for ischemic colitis other than the age. But I suppose, yeah, that is a fair point. Yeah.
Well, for me, ischemic colitis is a bit of an odd condition, because I've seen it in patients that have no comorbidities. They just suddenly develop diarrhea and come in extremely unwell. You give them supportive therapy, maybe a bit of antibiotics, and they get better. What's odd in her case is the way it's persisted for such a long time, which is atypical for ischemic colitis.
Yeah, that's what Chris is asking, whether it would linger. And as you say, it probably wouldn't. She is a bit different. And I mean, the other reality, though, is that elderly patients with UC, bona fide UC, can also be difficult to treat. You know, so those are some of the sort of characteristics of the elderly patient with IBD. They're also not necessarily straightforward, not in the diagnosis and certainly not in the treatment. I asked, the white counts were low or towards the low end of normal. He doesn't recall what the differential neutrophil and lymphocyte count was. So he says that we would need to be wary about whether azathioprine is contributing to these counts. I think that's a fair point. And the other thing Modise was that she was iron deficient. If I read your spreadsheet correctly, she was iron deficient. And I don't know if you've corrected that yet.
No, I think we haven't corrected that. No.
Yeah. So IV iron, you have access to the iron.
Yeah, we do have. Yeah.
That would be the way to go. Yeah. And why does she have a BMI of 19? That's atypical for a married African woman.
She's, yeah.
African woman.
No, she's healthy.
She's been ill, or I mean, is that her constitution anyway?
No, she's never really lost. As I mentioned, she doesn't get lost. No.
I just wonder
19,
whether
I think it's fine where she doesn't look.
it's just that for somebody with that BMI at that age with PR bleeding and diarrhea, I wonder if it's worth doing a CT abdomen to rule out an undeclared non-benign lesion. Do you think, Jill, that's fair or that's over-investigating?
Give you some information, but I think you've got to really go the route of ulcerative colitis and find out exactly what's going on here. And I agree with Rob that I think ischemic colitis lasting over a year is very, very unusual. And we've seen actually quite a few cases over the last year of acute severe ulcerative colitis, first-time presentation with just a 1 or 2 week history prior to it, which has always made us think, no, we're dealing with an infection here, and lo and behold, you do everything and it comes back as UC. So it does happen.
Mm. Do you have a dedicated pathologist, Modise, at your institution?
No.
Jill,
but of course, when you've got challenging pathologists, and we also speak to others like Prof Bida does help also.
Yeah.
So
I think it
questionable report on histology, we do take it up and then speak to them directly. So
yeah.
And then for reviews, sometimes reviews.
For me, the most important next investigation would be a good quality colonoscopy to see what the endoscopic picture is.
Yeah, and biopsies. Yeah. Are there any other comments? Would anyone infer? I mean, I think it's okay to have one diagnosis, UC. I suppose you couldn't infer microscopic colitis in this context as adding to the ongoing diarrhea despite therapy, because she does have microscopic disease. So
no,
I mean,
it
doesn't work that. It's a stretch. All right. Are there any other comments, folks? Either from these cases that have been presented or any of the cases that you have that are difficult to manage? I must say, we even here in a tertiary setting, we do have patients that don't neatly fit, either from the clinical history or the endoscopy or even the histology. And often you're still stuck with whether you think this is a chronic inflammatory condition or whether this is an infective process that maybe is taking a little bit longer to resolve. And whether you do take out the big guns to treat the patient or whether you wait it out. And I think, there's no... Hassan, we didn't get that. Would you mind to repeat that? Okay. Feel free to unmute when you want to. So yeah, it can be difficult when you have patients like this because you're really not sure what to do. But I think in her case, she's not resolving. It's not a case of watchful waiting. She's not resolving. So the only thing you can do is to try and confirm the diagnosis more firmly and then to escalate therapy. VG asks again, assuming this is UC, at which point do you call it refractory and refer to surgery? That's a good question. Probably VG after escalating to biologics, and she doesn't respond to that. But I think I personally would try to give medical therapy as far as possible. I mean, she has improved symptomatically in terms of a stool count, tachycardia, the blood pressure, etc. Her HB, can be improved as well. Her iron stores. But I wouldn't say that at this particular moment that she should be referred for surgery. I would let the surgeons know and contact the stoma therapist and of course speak to the patient and the patient's family. But I think there are still steps that we can do before we refer her to surgery. And of course, I think you have to do the radiology and monitor the CRP in the next few days, just to make sure that things are actually not getting worse and she's not having complications.
Sure. I'm Sheikh, if I can just add from that.
Yes,
So
please go ahead.
it isn't the acute severe colitis. For acute severe colitis, as from the first presentation with Jill, she gave us those very nice criteria, CRP greater than 45, call the surgeon, etc., etc. But when you have one of these ulcerative colitis patients that come in and out, their albumins are always low. You've tried azathioprine. If you have access to anti-TNFs, which we still have huge issues with for a number of years, you've tried that. Are there any hard criteria that we can reliably use other than our feelings that, you know, this patient's been in and out and we've given a couple of repeated steroid courses and some infliximab, and we keep giving some repeated course of IVI, and the fecal calprotectin is always over 800, etc., etc. We've gone and looked a few times. We've taken biopsies. We've looked for CMV. At which point do we use hard criteria to say, right, we stop here, other than our feelings?
So there's no hard criteria. Unfortunately, it does just come down to your clinical acumen and the patient's wishes. You know, I think down the line, we all know those patients where you've kind of scraped the barrel and there's really not much else you can do. But remember, patients do not want to have a stoma. And if you take somebody's colon out at the age of 68, the chances are she's always going to have a stoma, because surgeons would be very reluctant to construct an ileoanal pouch in a patient of that age. I stand to be corrected, especially if she's in very good shape. But I think, VG, it makes it very easy if you do a colonoscopy and the biopsy comes back with dysplasia. Well, that's a hard criteria. But sort of grumbling patient who doesn't quite fit the acute severe ulcerative colitis mold, and we all know the kind of person that you're talking. I think it's just a case-by-case basis.
And I think that's the importance of the MDT team. It has to be a collective decision that's supported by the doctors managing the patient. And it's a hard call, and you just have to have a discussion and document it well. Professor Casinidis, any final thoughts or comments?
Oh, just excellent session. Thank you very much.
You're most welcome. I don't see any further questions. And perhaps for once, we might actually finish within the time frame that has been given to us. So I'm going to hand over to Professor Watermeyer to do the closing.
Thank you. And thanks everybody for attending today's IBD Gecko. And I'd like to thank Modise and Machiko for speaking and for chairing. I'd also like to thank ECHO University of New Mexico, as well as the Gastro Foundation of South Africa, in particular Cheryl. And although Karen's not with us at the moment, we always consider her as part of the family. I would also like to thank some sponsors of this meeting, Takeda, Asino, Amgen, Equity, Aspen, and Adcock Ingram. So many thanks. It really makes life a lot easier if we have your support. And finally, there are some feedback forms available in the chat, so please fill these in if you can. And have a good evening, everybody, and we'll see you at our next Gecko.
Thanks so much, everyone. Bye-bye.
Thank you.
Bye.
Thanks, team. Bye.